Imagine going to your doctor because your physical anatomy is literally shrinking. Like the actual
Wow.
structural shape of your body is actively changing. It's causing you immense discomfort. And when you finally muster the courage to explain this, you're just handed a generic anti-itch cream and told it's probably just menopause.
Yeah, which is just, it's devastating.
It is. And today, for this deep dive, we are looking at a diagnostic blind spot so severe and honestly so misunderstood that it has the power to completely turn off the brain's sex drive.
It's a phenomenal example, really, of how a localized physical symptom can trigger a massive cascading physiological and psychological collapse. I mean, we aren't just talking about a skin issue here. We're talking about a condition that dismantles a person's relationship with their own body, with their partner, and their fundamental sense of desire.
Right. And to figure out how that actually happens, we have pulled together a serious stack of research for you today. We are pulling insights from clinical guidelines from the British Society for the Study of Vulval Disease and the Royal College of Obstetricians and Gynecologists.
Heavy hitters.
Exactly. And we're pairing that with detailed patient protocols from Oxford University hospitals, a sweeping British population survey on painful sex, and a really deeply personal qualitative interview study out of the University of Warwick.
Because looking at the sheer physical reality alongside that epidemiological data and the lived emotional experience of the patients is really the only way to actually answer the core question of this deep dive.
Okay, let's unpack this. Our mission today is to uncover exactly what vulval lichen sclerosus, or LS, actually is. How it creates this domino effect that impacts everything from physical anatomy to a person's psychological identity. And most importantly, does this condition actually cause a total loss of libido?
Right, the big question.
Yeah. But to even approach that sex drive question, we have to start with the physical reality of the condition itself. Like, what is actually happening?
Well, vulval lichen sclerosus is a chronic inflammatory skin condition. It primarily attacks the non-hair-bearing skin of the vulva, as well as the perineum and the skin directly around the anus.
Yeah.
And the mechanism here is essentially an autoimmune-like misfire. Basically, the body's immune system mistakenly targets the basal layer of the epidermis in these specific areas, and that causes chronic, localized inflammation.
And the symptom profile described in the research is just intense. I mean, we were talking about severe itching that completely ruins sleep, burning, soreness, stinging. But it's the structural changes that are the most alarming to me.
Oh, absolutely. The skin doesn't just feel different, it fundamentally transforms because that chronic inflammation disrupts the normal regeneration of skin cells.
It changes how the skin builds itself.
Exactly. The tissue can become very pale, like almost porcelain white, and incredibly thickened in some areas, but then it becomes paper thin and fragile in others.
Wow.
Yeah, and because the tissue is constantly inflamed and raw, when two raw surfaces rest against each other, like the inner lips of the vulva, the body tries to heal the area by bridging the gap with scar tissue.
Which leads to actual anatomical fusing, like parts of the body sticking together.
Yes. The architectural changes are profound. The inner lips can shrink, stick together, or just disappear completely into the surrounding tissue over time.
That is terrifying.
It is. The skin around the clitoris can fuse too, burying it completely beneath a layer of scarred skin. The entrance to the vagina can actually become narrowed and rigid.
Wait, okay, I'm stuck on the misdiagnosis part of this because the Warwick University qualitative study interviewed 20 women living with LS in the UK, and the overwhelming theme was this endless diagnostic runaround.
Yeah, the revolving door at the clinic.
Right. If a patient's anatomy is literally fusing together, how does a doctor just shrug and say, it's a yeast infection? Are they not looking?
A lot of times they frequently are not looking. It highlights a massive systemic reliance on verbal histories over physical examinations, especially when it comes to intimate health.
Wow. Just go off what the patient says.
Exactly. A patient presents complaining of vaginal itching or discomfort. The healthcare provider hears the word itch, and their brain immediately jumps to the most statistically common benign culprits.
Like recurrent thrush or candida?
Right. Or they just assume it's vaginal dryness associated with menopause.
There was one story in the study that really stuck with me about a patient named Janice. She was misdiagnosed for 4 years. 4 years.
Just heartbreaking.
She was dutifully applying over-the-counter thrush cream month after month while her anatomy was actively scarring and just being destroyed by this condition. The patients in the study felt completely disempowered.
I mean, think about it. It takes so much vulnerability to bring up an intimate problem in the first place, right? only to be handed a generic cream and dismissed without a proper examination.
Yeah, it's a huge betrayal of trust.
And while that dismissal is happening, the disease remains active. The localized immune attack continues, and the resulting architectural loss is largely irreversible once that scarring sets in.
So they're just left alone with it.
Exactly. This leaves the patient isolated with a condition that is progressively altering their body in absolute secret.
And when the body changes that drastically, the mechanics of intimacy fundamentally break down. Which brings us to the broader landscape of painful sex, clinically known as dyspareunia.
Yes, which is more common than people think.
Much more. The British population survey we looked at found that 7.5% of sexually active women in Britain report painful sex.
That's a huge number.
It is. And out of that group, nearly 2% experience what they call morbid pain, meaning it happens almost always, has lasted for over 6 months, and causes significant psychological distress.
And for someone with lichen sclerosus, that pain profile is highly specific. It's very mechanical. Because the inflammation leaves the skin so thin and devoid of its normal elasticity, simple friction or stretching causes microtears.
Just ripping the skin.
Literally, the tissue splits open. We were talking about skin that can tear from wearing tight jeans or riding a bicycle, let alone the physical friction of penetrative sex.
Right. If the inner lips have fused, or the entrance is narrowed from scar tissue, the sheer mechanical stretch of penetration is going to split that delicate skin right open.
Without a doubt.
So, to help you visualize what this does to the rest of the body, think of the pelvic floor muscles like a drawbridge. The pelvic floor is this complex hammock of muscles supporting the lower organs.
A great analogy.
Thanks. So when the vulval skin is sore, tearing, or even if you are just anticipating that it might hurt, that drawbridge instinctively pulls up and tightens to protect the castle.
It is an involuntary nervous system response. The pubococcygeus muscle and the surrounding pelvic floor structures attach to the base of the spine and sweep forward. The vulval skin lies directly over this muscular hammock.
They're completely connected.
Intimately connected. So when the brain detects skin pain or even registers profound anxiety about potential pain, it sends a reflex signal to those underlying muscles to brace for impact.
So it's a total lockdown.
An absolute lockdown. The muscles involuntarily spasm and tighten, which squeezes the lower third of the vagina, and this makes the entrance even smaller and incredibly rigid.
Oh, man.
Now, trying to push past that tightened entrance during sex doesn't just cause superficial skin tearing anymore, it causes deep, agonizing muscular pain. Penetration becomes structurally impossible without inflicting severe trauma.
Okay, so if the physical act of intimacy triggers this severe protective lockdown of the body, like if the drawbridge is permanently pulled up to defend against tearing skin, what does that fear and pain do to the brain's desire for sex in the first place?
That's the core question, isn't it?
Yeah. Does LS actually cause a total loss of libido?
Yes. The condition undeniably tanks the sex drive. But the mechanism isn't like a direct chemical attack on the brain's libido center.
It's not a hormone switch.
No, it is a psychological and physiological short circuit driven by chronic pain and anxiety.
And the clinical literature breaks down human desire into 2 distinct categories, which I think explains this perfectly. There is spontaneous sex drive, and there is responsive sex drive.
Right, and spontaneous desire is the culturally dominant idea of a sex drive, is the day-to-day random sexual thoughts, fantasies, or feelings of arousal that just bubble up out of nowhere.
Like you're doing the dishes and suddenly you're in the mood.
Exactly. But responsive desire is entirely different. It is arousal that builds sequentially in response to pleasurable stimuli, intimacy, or touch with a partner.
And the anxiety short circuit we were just talking about, it destroys both of them.
Completely.
For spontaneous desire, it all comes down to classical conditioning. If a person consistently experiences painful intercourse, if every single attempt ends with tearing skin or that agonizing pelvic muscle spasm, the brain physically rewires itself to associate sex with trauma.
Right. The stress hormone cortisol spikes at the mere thought of intimacy, which actively suppresses the physiological pathways related to arousal.
It's self-preservation.
Exactly. The brain essentially says, why would I spontaneously generate a desire for an activity that threatens my physical safety? So the spontaneous drive is systematically extinguished.
And responsive desire doesn't fare any better. If your partner leans in to touch you, and your immediate physiological reaction is sheer terror that this touch will inevitably lead to pain, your arousal process is paralyzed before it even begins.
You can't relax.
Right. If touch provokes an adrenaline spike of anxiety rather than a wave of pleasure, the responsive drive just never gets the necessary runway to take off.
And the timing of the disease onset makes this even more complex because lichen sclerosus frequently peaks or presents in a woman's 40s and 50s.
Right in the middle of perimenopause and menopause.
Exactly, which introduces a massive confounding variable. The natural drop in estrogen during menopause causes the vaginal and vulval tissues to become thinner, drier, and less elastic on their own.
Plus, menopause naturally impacts the baseline sex drive anyway and disrupts sleep through things like night sweats.
Yeah, so you have this brutal overlapping of symptoms. The lack of estrogen makes the tissues even more fragile, actively compounding the tearing and architectural damage caused by the LS inflammation.
It's like a perfect storm. A patient is left trying to untangle an impossible knot. Like, is their libido gone because their hormones crashed? Is it the severe sleep deprivation from the chronic itching? Is it the classical conditioning from the skin tearing?
The clinical reality is that it is the compounding weight of all those factors simultaneously. And if we connect this to the bigger picture, the psychological fallout of that loss extends far beyond the bedroom. It bleeds into a person's fundamental sense of identity.
Which brings us back to the Warwick research and this devastating theme of a secret life.
It's so common with this.
Because of the intense societal stigma surrounding female genitalia and honestly a widespread lack of basic anatomical education, patients hide this condition from everyone.
They suffer in silence.
They really do. They don't talk to their friends about it. Often they struggle to even articulate it to their own partners.
Because there is a heavy emotional burden in watching your own body change against your will, especially in an area so deeply tied to cultural notions of femininity and sexual viability.
Yeah. One patient in the study perfectly articulated this by saying she felt like an invisibility cloak had been thrown over her womanhood.
That quote is it's haunting.
It is, because her physical anatomy was actively eroding and her capacity for sexual intimacy had vanished. She felt her very identity as a woman was being erased.
And that profound loss of identity, combined with the inability to openly communicate the physical reality of the pain, creates a tragic relational dynamic between partners.
The affection avoidance cycle.
Yes.
The Oxford Clinical Patient Info warns about this explicitly because it destroys relationships. A person with LS will start proactively dodging all day-to-day non-sexual affection.
They pull away.
They will refuse a simple hug in the kitchen or pull away from a kiss on the sofa.
And the partner often interprets this as emotional coldness or a loss of love. But it is driven by sheer preservation. The person with LS is terrified that if they accept that hug, the partner will interpret it as a green light for penetrative sex.
Because that's what hugs used to mean.
Right. And knowing that sex will result in agonizing pain and skin tearing, they shut down the very first domino. They reject all physical contact to guarantee they don't end up in a situation where they have to endure the pain or, face the guilt of stopping things later.
The drawbridge goes up before the enemy is even in sight.
Exactly.
And so the partner feels entirely rejected, the emotional distance between them widens, and the environment required to nurture any remaining responsive libido is completely destroyed.
But here's where it gets really interesting. We have to look at how the medical management of the condition actively complicates the return of that libido.
Yeah, the paradox of the treatment. To halt the progression of the disease and stop the anatomical scarring, the treatment protocol is extremely aggressive. The guidelines dictate the use of ultrapotent steroid ointments, specifically medications like clobetasol propionate.
And those potent steroids are necessary. They are needed to forcibly suppress the localized immune response. By shutting down that overactive inflammation, the skin stops attacking itself and the architectural fusing is finally halted.
Which is great.
It is, but managing the condition requires an intense daily regimen.
Right. Patients have to wash exclusively with soap substitutes, carefully apply the potent steroids, and use heavy, greasy emollients multiple times a day to act as a barrier.
To protect the vulnerable skin from the acidic irritation of urine and just simple mechanical friction.
It is an incredibly high-maintenance clinical routine. One patient described going to the bathroom as no longer spending a penny, it's like spending 10 pence, because of the elaborate routine of wiping, creaming, and barrier protection required every single time.
And consider the psychological impact of that routine on sexual desire. Applying messy, heavy ointments to your genitals multiple times a day actively desexualizes the body.
You feel like a medical patient managing a wound. not a sexual being capable of pleasure.
Exactly. Having greasy emollients on the skin can make the idea of sexual touch feel clinically awkward and really unappealing. It drives just another wedge into the already fractured libido.
So the landscape we've painted is objectively bleak. You have an autoimmune-like mechanism destroying the anatomy, severe chronic pain triggering a pelvic floor lockdown, classical conditioning erasing spontaneous desire, profound relational isolation, and a messy, unsexy daily medical routine.
It perfectly answers our central question of why the libido disappears.
It really does. But the sources don't just leave us with the diagnosis. They provide a remarkably empowering, evidence-based roadmap for reversing the short circuit and actually reclaiming intimacy.
Yes, there is hope. Recovery requires a two-pronged approach, really. Physiological optimization and psychological rewiring.
Okay, let's start with physiological.
Physiologically, adherence to the potent steroid regimen is non-negotiable.
Right. The guidelines note that a standard 30-gram tube of the ultra-potent steroid should last a patient about 3 months. When applied correctly and consistently, it is highly effective at halting the disease progression, preventing acute flare-ups, and restoring the skin's baseline integrity so it stops tearing from minor friction.
And alongside the steroids, addressing that menopausal overlap we talked about is critical.
The estrogen piece.
Yes. Applying local estrogen creams directly to the vulval tissue and inside the vagina helps increase localized blood flow and collagen production. This restores elasticity and thickness to the tissues that the steroids and LS alone cannot fix.
And the proactive use of high-quality lubricants is heavily emphasized in the sources. Not just waiting until things feel dry during intimacy, but using them deliberately to reduce friction and protect the healing skin.
Very important.
So, a quick safety note from the clinical guidelines for you. If a couple relies on latex condoms, they cannot use oil-based lubricants or apply their heavy steroid ointments immediately before sex. The oil chemically degrades the latex almost instantly, causing the condom to fail. Water-based or silicone-based lubricants are required.
Good catch. So, once the physical tissue is medically optimized and the acute tearing is under control, the real work of restoring the libido begins, and it requires a complete paradigm shift in how a couple views sex.
The Oxford Patient Protocols introduce a brilliant concept to help couples navigate this. Sex is a menu.
I love this concept.
Culturally, we are deeply conditioned to view penetrative sex penis in vagina as the only main course. Everything else is just an appetizer leading to that specific destination.
But for a patient with lichen sclerosus, because of the historical tissue damage, the narrowed entrance, or the lingering drawbridge effect of the pelvic floor, that specific item on the menu might be completely unavailable.
Right, it might be off the menu temporarily while the steroids work, or permanently due to severe anatomical fusing.
And if you walk into a restaurant and they are out of the one dish you always order, the instinct is to just leave the restaurant.
Which is exactly what happens in the affection avoidance cycle. Couples stop touching entirely because real sex is off the table. The menu concept challenges couples to actively explore the rest of the options available to them.
Because the menu of intimacy is vast. It includes prolonged eye contact, deep tactile massage, outer course, mutual masturbation, reading erotica together, or the use of vibration.
The clinical application of vibration is fascinating to me. The patient information suggests that vibrators can be incredibly useful tools for overcoming the physical lockdown.
It operates on the sensory gate control theory of pain. The vibrations provide a massive amount of sensory input to the localized nerve endings. This intensive stimulation essentially overrides or distracts the brain's focus on the anticipated pain of stretching.
So it bypasses the involuntary tightening reflex of the pelvic floor muscles.
Exactly. It allows arousal to build without triggering the drawbridge to slam shut.
But to safely explore this menu and utilize these tools, established couples are advised to do something that sounds incredibly cliché, but is psychologically essential. They have to start dating again.
Yes. In a long-term relationship, intimacy often relies heavily on that spontaneous desire we talked about earlier.
Right, it happens quickly, squeezed between daily obligations.
But since LS has systematically destroyed spontaneous desire, relying on it guarantees failure.
By setting deliberate, scheduled, protected time for intimacy a date, you intentionally change the psychological environment. And the absolute most critical rule of this date is that penetrative sex is explicitly banned. It is taken off the table entirely.
Which removes the threat.
Exactly. When the brain knows with absolute certainty that penetration and therefore tearing and pain will not occur, the anxiety short circuit is finally bypassed. The cortisol levels drop, the pelvic floor drawbridge can slowly lower.
In that safe, highly controlled, low-pressure environment, the brain's responsive libido is given the psychological safety it needs to return. The nervous system can finally experience touch as pleasurable rather than threatening.
It is not a quick fix. It requires radical, open communication, immense patience, and a willingness for both partners to unlearn a lifetime of cultural assumptions about what successful intimacy looks like.
But the clinical evidence demonstrates that this psychological rewiring absolutely works.
So what does this all mean? Lichen sclerosus is a chronic, inflammatory autoimmune misfire that systematically attacks the anatomy of the vulva. The resulting physical trauma and tearing triggers an involuntary tightening of the pelvic floor muscles. That combination of pain and tension completely short-circuits the brain's libido through classical conditioning and severe anxiety.
Add in the heavy societal stigma surrounding intimate health, and you have patients suffering in absolute silence, mourning the perceived loss of their womanhood.
Yet, with aggressive clinical treatment, utilizing ultrapotent steroids and local estrogen to optimize the physical tissue, combined with a radical reimagining of intimacy as a broad, non-penetrative menu, a deeply connected, fulfilling sex life can be reclaimed.
It represents a forced, but ultimately profound evolution of a couple's intimacy. And this raises an important question, though, one that extends far beyond the realm of lichen sclerosus or any medical diagnosis.
What's that?
Our broader society heavily relies on the concept of spontaneous desire as the ultimate metric of a healthy romantic relationship. We are bombarded by it in movies, television, pop culture, this pervasive idea that true passion means constantly being swept away by a sudden, spontaneous urge for your partner.
Right, and if you aren't experiencing that spontaneous lightning bolt, the cultural narrative suggests your relationship is failing or your sex drive is broken.
Exactly. But if we look at the immense success of these clinical protocols, what if we all embraced the reality of responsive desire? What if we recognize that for many people, arousal isn't a spontaneous event, but something that must be actively, deliberately cultivated in a safe, low-pressure environment?
Wow. How much performance anxiety and quiet disappointment could we eliminate from our own intimate lives if we stopped waiting around for the lightning bolt to strike and simply learned how to build the fire together instead?
It's a massive paradigm shift.
It really is. Well, that is all the time we have for today's deep dive. To you, our listener, thank you so much for joining us on this exploration. Keep questioning the things you think you know. And remember, when the standard diagnostic tools fail to see the problem, you have to look at the entire cascading picture to understand why the drawbridge was pulled up in the first place. Keep learning, and we'll catch you next time.